Welcome to today's Explainer. We're jumping right into the high-stakes world of the emergency room today. When a patient rolls in clutching their chest, you know the very first thing an ER doctor looks at is the ECG. Those electrical squiggles literally tell the story of the heart. But here's the catch. Not all lethal heart conditions announce themselves clearly. Some are incredibly sneaky. So today we're going to learn exactly how emergency physicians use a strict mental checklist to spot these hidden killers. And to really get this right, we need an ECG picture for each pattern so we can train our eyes just like the pros do. Let's get into it.
Think of our agenda today as a high-stakes triage board. We've got 5 key areas. First, the sneaky heart attacks. Second, fast electrical killers. Third, toxic electrolytes. Fourth, critical ER syndromes. And finally, number 5, the golden rules.
Okay, before we hunt for the hidden killers, we have to know what the obvious one looks like, right? A STEMI, or ST elevation myocardial infarction, is your classic screaming siren heart attack. If you look at the ECG picture for this pattern, notice how that ST segment is elevated. It practically looks like a tombstone. It's super obvious. But what happens when a patient is having a massive, life-threatening blockage, but their ECG doesn't have this classic tombstone elevation?
Section 1. The sneaky heart attacks. Let's dive into this.
Missing these means delaying life-saving treatment, so we really need to look at the ECG picture for each pattern here. First up is the posterior MI. Because standard ECG leads sit on the front of the chest, a heart attack on the back of the heart actually shows up backward. You'll see ST depression in leads V1 through V3 along with tall R waves. It's essentially a mirror image of a STEMI. Next is Wellens syndrome. Man, this one is deceptive. A patient might be sitting right in front of you, completely pain-free. But if you see deeply inverted or biphasic T waves in leads V2 and V3, sound the alarm. It means the widowmaker artery is practically choked off. Finally, check out the De Winter pattern. Look at that upsloping ST depression leading right into a tall, symmetric T wave. No classic elevation, sure, but it is 100% equivalent to a fatal occlusion.
Let's look at 2 more massive early warning signs. If you see ST elevation isolated in just the AVR lead, but it's accompanied by widespread ST depression everywhere else, you're looking at a screaming red flag for severe triple vessel disease or a total left main coronary artery occlusion. The entire heart is literally starving for oxygen. And then we have hyperacute T waves. These are broad, tall, and symmetric. Spotting these means you're actually catching a STEMI in its absolute infancy, literally right before that classic tombstone elevation even has time to show up.
Section 2. Fast electrical killers. Let's speed things up a bit.
So we've covered plumbing problems, but now we're shifting to the wiring. Imagine a ticking clock, because these fast electrical killers can end a life in minutes. Have you ever heard of torsades des points? It's a French term, and it literally translates to twisting of the points. When you look at the ECG picture for this pattern, instead of a steady rhythm, the QRS complexes appear to be twisting around the baseline in this chaotic, ribbon-like shape. It's a highly dangerous ventricular tachycardia that strikes when the heart's electrical recharge time gets stretched out way too long.
The crucial point here is rapid recognition. First, ventricular tachycardia, or VT. Notice the wide complex waveform. Now, here's a golden rule in the ER. If you see a wide, fast rhythm, you always treat it as VT unless proven otherwise. The risk of being wrong is just too high. Next is ventricular fibrillation, or VF. Notice there are no organized QRS complexes at all, just a chaotic, squiggly baseline. The heart isn't pumping, it's just quivering. This is sudden cardiac arrest and requires an immediate shock to reset the heart. Finally, the third-degree AV block. The top and bottom of the heart have completely stopped talking to each other. It's a complete electrical block, and the sudden death risk is huge.
Now, not all fast rhythms start in the bottom of the heart. Atrial fibrillation, or AFib, is super common, but when it becomes extremely rapid and causes instability, like the patient's blood pressure is tanking or they're showing signs of ischemia, well, it stops being routine. Just like VF, unstable rapid AFib requires urgent cardioversion. We literally have to shock the heart back into a normal rhythm before vital organs start shutting down.
Okay, so we've looked at blocked pipes and faulty wires, but let's pivot for a second. What happens when the physical structure of the heart is completely fine, but the blood pumping through it is chemically toxic? How does that actually warp the patterns on the monitor?
Section 3. Toxic electrolytes. Let's take a look.
What's really fascinating here is how chemical imbalances physically distort the heart's rhythm. Potassium is the primary fuel for the heart's electrical reset. First, we have hyperkalemia. too much potassium. When you look at the ECG picture for this pattern, the very first sign is tall, pinched, peaked T waves, followed by a widening QRS complex. It looks like the waves are being physically pulled upward. On the flip side, hypokalemia, too little potassium. The T waves flatten out entirely, and you might even see an extra bump called a U wave. Both of these extremes drastically increase the risk of a fatal arrhythmia.
Let's zero in on hypotassium for a second, because it follows a terrifying chronological progression. I want you to visualize this electrical wave morphing over time. Step 1, you get those peaked T waves. Step 2, the PR interval prolongs as the electrical signal starts slowing down. Step 3, the QRS complex gets wider and wider until it actually merges with the T wave, forming a sine wave. It literally looks like a smooth, rolling wave of water. If you see a sine wave, you are at step 4, imminent cardiac arrest. You have maybe minutes to shift that potassium where the patient will flatline.
And potassium isn't the only culprit. Calcium plays a massive role too. Think back to Torsades de points and that twisting ribbon pattern. Hypocalcemia, or low calcium, physically stretches out the heart's recharge time, creating a long QT interval. That long QT is exactly what triggers torsades. Conversely, hypercalcemia, or high calcium, compresses that recharge time into a short QT interval. It's almost like an accordion, right? The trace expands and contracts based entirely on the calcium in the blood.
Section 4. Critical ER syndromes.
This section dives into the truly sneaky syndromes where you need an eagle eye to spot the clues. Let's talk about pulmonary embolisms, or PEs, blood clots in the lungs. Textbooks will tell you to hunt for the famous S1Q3T3 pattern, and we certainly do look for that. But here's the real-world truth. The absolute most common finding for a PE is simply sinus tachycardia, just a fast, normal-looking heart rate. You also need to look for right heart strain, which shows up as T-wave inversions in leads V1 through V4, simply because that clot is causing pressure to back up into the right side of the heart.
Now check out these genetic and structural traps. Brugada syndrome has a very distinct, coved, almost ski slope-like ST elevation in V1 through V3. It's a genetic mutation with a massive risk of sudden cardiac death, often in completely young, healthy people. Then we have Wolff-Parkinson-White, or WPW. Look at the ECG picture for this pattern. You'll see a short PR interval and a slurred upstroke called a delta wave. That represents a hidden extra electrical pathway. It's usually fine until the patient goes into AFib, and then that extra pathway can trigger deadly ventricular fibrillation. And of course, long QT. Whether it's genetic or chemical, that prolonged QT is a direct, terrifying path straight to torsades. Next, we absolutely have to contrast two distinct mimics. On the top, pericarditis, inflammation of the sac around the heart. Its tracing shows diffuse ST elevation everywhere. It's not localized to just one artery, and you'll see PR depression. But on the bottom is a right ventricular infarct. This looks like a standard inferior STEMI, but if the patient has low blood pressure, you have to check lead V4R on the right side of the chest. If you see elevation there, it's an RV infarct. And this is critical. If you give this patient common chest pain drugs like nitrates, you will completely tank their blood pressure and potentially kill them. Now here is a totally fascinating and terrifying mechanical problem: cardiac tamponade. This happens when fluid rapidly fills the sac around the heart, literally crushing it. Because the heart is swinging back and forth in a pool of fluid with every single beat, its physical distance from the ECG leads keeps changing. The monitor perfectly captures this. You'll see low voltage overall and electrical alternance, where the QRS complexes alternate between tall and short, tall and short. It is literally mirroring the swinging of a drowning heart.
Section 5. Golden Rules. Let's bring this all together.
To survive the ER, doctors rely on practical heuristics. Let's lock these golden rules into your memory. If you see atypical ST changes that don't fit a clean textbook STEMI, immediately think of those sneaky equivalents we talked about. If you see a wide complex tachycardia, just assume it's VT and prepare to act. If you spot peaked T waves, your brain should immediately jump to hyperkalemia until blood tests prove otherwise. And if you see unusual ST segments in leads V1 through V3, you absolutely must consider Brugada syndrome or a hidden posterior MI.
But even with these rules, some patterns just consistently trip people up, from med students to seasoned doctors. These are the absolute stealthiest killers on our board: the posterior MI, the De Winter pattern, Wellens syndrome, the early hyperkalemia ECG, and a Brugada pattern. We've looked at the exact diagnostic ECG pictures for every single one of these today, totally stripping away their camouflage. We've demystified the squiggles, right? We've seen how blocked pipes, chaotic wiring, toxic fuel, and hidden structural traps paint very specific, incredibly urgent pictures on a monitor. So, I leave you with this. If you were handed an ECG right now, looking at those lines,
Would you spot the silent killer before the clock runs out? Keep reviewing these patterns. Respect the incredible diagnostic power of this simple tool, and whatever you do, never stop learning. Thanks for joining me on